All right, welcome to Spine Conference. Today's discussion is going to be synovial cysts of the lumbar spine. And just a reminder, I record everything and it's being posted on the internet, so keep all comments rated E for everyone. So I like to do individual cases because they're real and you can learn from them. So this is a 63-year-old man who presented to my office with a right foot drop, a complete right foot drop. And he said he had symptoms for a month since around July 20th. He had some sciatica, and then over the course of 6 weeks, he had a complete right foot drop. So he called his primary care physician, and he's actually my patient. I'm not sure why he called the primary care physician, but he called the primary care physician who gave him some steroids. He did not get better. He had a previous L4, L5 fusion 6 months prior to presentation, and he did extremely well. Other than he has a congenital renal cyst, high blood pressure, he's relatively healthy. He works as an electrician. So he comes in with these x-rays. We're going to go over Dr. Sexton, we're going to go over the imaging first, but since he just basically 6 months ago had surgery, I said, well, let me look at his past medical history and go over his whole case before I start getting more imaging. So let's see what happened in the past. So this is how he presented his x-ray from a year ago. And what do you think of, what are your thoughts, Dr. Sexton, on the x-ray? This is 1 year ago now.
Right. So we're looking at expanding PA and the lateral flexion. On the PA, there's a slight left. This is up for the spine surgeon. Way of looking at things, you got to be careful. So there's a mild left convex scoliosis. There is moderate, or at least moderate, right L4 5% hypertrophy with osteophyte formation. SI joints are okay. Unilateral, there's in 5 millimeters of L4 and L5 spondylolisthesis. It's a mild degenerative disc disease up and down.
So when I look at these images, Paul, I usually describe the like subluxation on the APU. I feel it's important. Do you feel that that's important? What are your thoughts?
There's clearly, I think, a left lateral listhesis.
But at 4 or 5, see that?
Yeah.
So I think
part
that's
of the spinal deformity.
I think that's a instability on top of the spondylolisthesis. So you know it's kind of like in 2 planes. I mean, that's what I've always thought. Okay, so I want to go through these sort of quickly because these are just the past medical history. So, Dr. Sexton, what do you think?
So the T2 similarly shows the L4 and L5 spondylolisthesis with a moderate disc bulge and midline mild stenosis with cords like superlateral recesses and foramina, which are going to be important.
Okay, and let's go over these. Are the axial cuts from a year ago, 5-1.
Huh? What's that? So we're at the L5S1 disc level, I believe.
Yeah.
And we're seeing an asymmetric left foraminal stenosis. Now, got to be careful about laterality here. Remember that on the radiographs at the low lumbar spine, there was a I got to get that PA lumbar spine out of my head. This is the left side, which is the stomach level was over here. Okay, so this is along the concave margin of the low lumbar spine, so that all makes sense. So moderate left lateral recesses and left foraminal stenosis at L5S1.
Okay, and 4-5.
Moderate percent hypertrophy, some fluid and synovial fluid in facets, and moderate, at least moderate bilateral foraminal stenosis.
And when I see fluid within the synovial, I always think dynamic spondylolisthesis until proven otherwise. Do you think that, Paul?
Absolutely.
Yeah.
Set diastasis, and that's a sign of instability. And why is that? We're just guessing. Why is that? Why do you have, when you have, if you see fluid in the facet, you have a normal, but your sagittal MRI image looks normal. What's going on there? Talk louder because we can't hear you.
Sorry, it's all because our lane's fine.
And what happens when you lay supine?
So, I mean, probably it reduces the spine.
Right. So a lot of times that can be missed by radiologists if they don't have dynamic x-rays. They see that the spine is reduced, but you see a big gapping of the facet because the spine reduces when the person lays down, right? So that's a sign of instability when you see fluid or diastasis in the facet joints.
I think the problem is not everybody gets dynamic x-rays because they're difficult. Like the standard is laying, it's easy to get with the patient supine, you get a nicer x-ray. So I think that's a big problem.
That's why we do slump sitting flexion.
I do lateral decubitus flexion.
It's been shown that there's a study that slump sitting, it's easier to do.
Sitting position?
And it's more sensitive for instability than a standing or supine flexion image.
So sitting flexion.
Sitting slump, so they
Slump.
just basically flex their spine. It's more comfortable, and that's, I have the article I can show you.
Okay, that's
Remember, in that article, it's more sensitive for demonstrating angular rotational instability, not translational instability. So the degree of slip anteriorly is a little different on the slump versus standard flexion section. But if you're looking at both this difference with it,
okay.
figure out what you feel more time.
Okay, so let me, there's a lot to go over, so I'm just going to move a little quickly. So 3-4 was relatively normal. I just to look, I'm not going to go, I'm going to do this quickly. This is just my technique of putting pedicle screws, is get a lateral, and we're going to go clockwise. Put a clamp, prove your level, put a probe in the pedicle, place the screw, and then the next level, and then just put in 4 screws like that. And then check an AP view. I do everything lateral, check an AP view. And I was concerned maybe one of the screws was lateral, so I did a, on the right upper, I took an x-ray with the screw as a dot, and then I could see that I was in the vertebral body, an oblique view. And then finished up, and he did extremely well post-op day 1. He was very happy, very, very happy person. So now he's back. And he's got a right foot drop for a month. So, I mean, I don't know if anybody criticized me, immediately the guy needs an MRI. He's got a right foot drop. Does anybody think otherwise? So he gets an MRI. So here's the MRI. What do you, Dr. Sexton, if you don't mind, what are your thoughts here in sagittal cuts?
Okay, so this looks like on our left, a fat saturated T2. We talk about that as being more sensitive for fluid in the vertebral bodies than a standard T2. So the vertebral bodies look okay in both sequences in terms of nothing going on inside infection, tumor, etc. Conus is normal for at least the region where one would expect the conus is normal. It must be just a little bit out of the field of view. The area of decompression at 4-5 looks fine. L5S1 looks fine, at least in the center of the canal. And then on our left side image, there's something that looks like a reverse C. We'll try to sort that out. And then on the right, we must be a little bit off midline. And the right-sided symptomatology, I'm going to say we're a little off the right side of the midline. And I see there's a 17 millimeter phenomenon there that is bright on T2 with a dark rim. So maybe I'll leave it at that for the moment. You want to show me another thing? I want to have a discussion.
No, let's keep, there's a lot of images, so if you don't mind, we'll keep moving.
Yeah.
So here's an axial cut.
Okay, so this is showing the same thing axially. It's a little bit more obvious what's going on and where it's going on. So we have an extradural lesion pushing the dura to the left. It's in a lateral recess. It's predominantly bright on T2 with a dark rim, and it's right up against the facet joint, so that fits into the topic for this morning. This would be a facet joint cyst creating moderate to marked right lateral recess and right foraminal stenosis.
One more. So a little bit far. This one's a little bit more caudal.
Yeah, okay. A little more caudally. We're catching the bottom of the right-sided lesion, and we're catching a left-sided lesion from the more inferior left L34 facet, and you can see that the thecal sac is extremely compressed, particularly on the right, but also on the left.
And one more, a little bit farther down.
So we're seeing on the left sort of a hypertrophy ligament and flavum, maybe the bottom of that left-sided facet joint cyst.
So remember the pre-op that from a year ago, 3-4 was pretty normal. So here the ligament flavum is very hypertrophic. So that's just 6 months. Okay, so just to be complete is we'll just a couple 3 or 4 more L4.
Okay, so we're showing us a posterior posterior facet cyst. Obviously not affecting the spinal canal, but from that same L3-4 facet at its bottom margin.
And level of decompression.
And there's your surgery now.
And 5-1, just to be complete. And 2-3.
Mild.
Okay, so like what Dr. Sexton said this was so any questions so far? Okay, so is a synovial cyst or juxtafacet cyst or maybe it's a ganglion cyst, or some people call it cystic malformations, mobile spine, intraspinal extradural ganglion cyst, pseudocyst. So most likely this is emanating from the facet. So the facet joint, if anybody has questions or they disagree with me, please interrupt me. Facet joint is basically a joint like a knee, but it's very small. It moves, it has a synovial capsule, and it connects 2 bones. And every facet joint of the lumbar spine has its own characteristic shape. And at L1, L2, L2, L3, it's very easy to stuff bone into the facet because it's angled vertically, and it's a lot harder at 5-1. So you can see here, this is a nice image on the right, the variable angle of each facet of the lumbar spine. It's a synovial joint, so it's covered, it's just like a knee basically, just like this toe, and it has a cartilage in it, it has cortical bone, it has a synovial membrane with synovial cells that create synovial fluid. So just like a Baker cyst in the knee, you can develop a synovial cyst in the facet joint. The problem is if the facet joint goes posterior, it doesn't mean anything really, but if it goes anterior, it compresses the nerve roots. So this is the most recent large article that I thought was good that I sent to everyone, Journal of Neurosurgery Spine 2017. It's from Frankfurt, and it's 141, this is Frankfurt, 141 cases over 7 years, oh no more than 7 years, 17 years over a single center, retrospective, and they did partial hemilaminectomy in most of the cases. They used a microscope in every case, hemilaminectomy. They gave them different treatment options, and the question is a fusion necessary for these patients? There was long-term follow-up, 9 years, and most of the cases were L4, L5, 61%. Almost half had sensory changes, 40% had weakness, and 1 out of 5 had spondylolisthesis. And 72% of the cysts were adherent to the dura, and almost always they removed the whole cyst, 94%. They had 8% dural tears and CSF leaks, 5%. And the people did extremely well with low back pain and sensory improvement. The motor deficits did not improve so much. 22% got better, and 1% had a post-op hematoma, had to be evacuated. And the failures, 6% had recurrent cysts over the 9 years. 3 out of 8 were in the first year. And 6% of patients developed spondylolisthesis that needed a fusion. This is just the long term, most of the people were L4, L5, L5S1, L3, L4. And most of the cysts, 98% in this study and 92% in literature, come from the lumbar spine. So facet cysts are usually lumbar spine. Okay, so I just want to go over a couple different cysts. This is a different case. 21-year-old man, this is a patient of mine actually, right thigh pain, numbness. He's an avid power lifter. He's really big, strong, thick guy, young man, 21 years old. What do you think here, Dr. Sexton?
Conus is normal, bones are normal, and at L3-4 circled a bulging posterior disc, and also circled what may likely turn out to be a facet joint cyst there, sort of ventral in the canal, but I'm sure when we get an axial, it'll look like it's come around the corner a little bit. So based on the topic of the day and the markings, I would say L3-4 facet joint cyst.
Now, so Since we're talking about facet cysts, the character, here's the axial cut. This, I think, is a different appearing cyst than the last one, in the sense, go ahead, why don't you think?
Well, yeah, it's signal characteristics are homogeneously very bright, so one would anticipate this is more homogeneously fluid, mucoid, synovial cystic fluid, what have you. The other one maybe just a little bit more solid.
Yeah, it was more heterogeneous, wasn't it? It looked more solid.
Yeah.
And this one came out in one piece and was like a little ball and was more like a ganglion cyst. I don't think this had synovium in it. So from the study, from the review study that I gave everybody from the Yellow Journal, there was an article that showed 63% was mucoid, 19% serous, and 14% hemorrhagic. So this one was a serous cyst. Okay. Now here's another case.
Hold on one second.
Yeah.
So I think that's probably called stratification. So Megan, where else in the body can you get synovial cyst? What are the areas where you ever see it? And then again, what do you call it there? Okay, any place else? Foot. Okay. Where else? Baker's system, knee. Right? Basically any joint. Right. So what's the cyst made out of? What are the contents of the cyst? Synovial fluid, right? And what else is in synovial fluid? What comprises synovial fluid? Anything. There's got to be something in there, right? Give me the context.
Is what all the nutrients which supply the synovial joint.
Coated lichens. What else? It's fluid, so there's got to be something fluid. Water. Okay. Water, proteins, cells, synovial cells, red cells, white cells. Okay. Basically what's in your joint. So whether it's mucoid because there's relatively less water content, or serous because there's relatively more, or it's hemorrhagic because someone was powerlifting and they had a little bleed that got into the synovium and they bled into this cyst. I don't think that stratification really, it's all synovial crap, basically, right? You can't really differentiate that way.
Some have synovium in it and some don't. Some are just no synovial membrane.
Synovium. It's whether or not it has a lot of water content. It's all a synovial system. There's none of these that are not part of the synovial joint. It's all part of that.
Let me show you another one that may change your mind. Okay. So here's another. This is actually a patient of mine too. 65-year-old man with low back pain, 2 to 3 months history of low back pain, left buttock pain. He has gout, diabetes, social history is normal. He's a hotel executive, 5'8", 240. So what do you think of Dr. Sexton sagittal cuts here?
Well, cut to the chase, we're looking at another facet joint cyst centered at L3, L4, and at the top is a low signal component, which, again, just to emphasize the continuum, fluid's going to be completely bright, mucoid, mixoid going to be intermediate, and then dark can be anything from scarring to calcification to ossification, and so there's a significant either spurring or that sort of thing with this lesion.
Okay, here's another view.
So this is interesting. We're looking at a T1 sequence here, and I know it's T1 for those who are just getting a look at this sort of thing because the CSF is dark, the fat is bright, and the lesion is bright. Now, the question becomes, this is a little bit of an artificial exercise, but still good, is this contrast enhanced or not? That's
I think, wait a minute, is this hold on a second, is this contrast?
no.
Okay.
But so the way we generally tell whether it's contrast enhanced. Sometimes, well, it's always useful to understand how to identify a contrast enhanced scan because it can be marked contrast, but the patient got the whole dosage of their subcutaneous tissues of their antecubital fossa, or it can be any kind of clerical mistake potentially. So, so I get to ask an imaging question. If this is bright on T1, we've said it could be enhancement. That would be the first thing I would think about, actually, if bright on T1. And how do I know by looking at these images if these are not contrast enhanced? Any of the residents want to be a star on this one? Well, the basivertebral vein lights up on T1 with contrast. And so you can see that these are not. So this is intrinsically bright on T1. And that turns out to be two potential in the differential. One, it's fat. So this is not the location of a fat lesion. There are certainly fat lesions in the filum terminale and the cardia equina and in the sacral canal, fat lesions, but this is in no way in that location. So we're going to dispense with that, and then blood. And so this is a cyst into which there has been bleeding, and not today, but could have been a week ago, could have been a month ago, probably not years ago, because that generally coalesces into a black fibrotic sclerotic focus. So hemorrhagic cyst, and I've never seen one.
Here's another view.
This is now, these are T2, so these are giving us similar information to what we wrote.
You've never seen one, really? Is that rare?
I've never seen a bright T1 synovial cyst.
Okay.
No, never have. So,
It's not T2.
no, it's not, Paul. No, thank you. Thank you. It's not. This is a T1, and you can see the basivertebral vein and the lighting up along the posterior margin of the vertebral bodies going into their canal. So thank you. This is a T1 post contrast. So this is another good lesson. So one would jump to the conclusion that this is a solid enhancing mass, because 9 times out of 10, certainly in the spine, 99 times out of 100, a bright lesion on post-contrast study will have enhanced. So the first thing we always do if we think something is enhancing is check back on the pre-contrast. And on the pre-contrast, you remember it was bright. So this is intrinsically bright. Could there be an element of enhancement? Yeah. Is all that bright enhancement? No. Is this likely solid? No, because it was all bright on T1. And all solid things are, well, it could be solid fat, which we dispense with, or it could be hemorrhage.
All right, a couple more axial views. This is at the L304 disc space.
Okay.
It's not a good image, and I'm sorry, because it's open magnet.
Image is just big. So let's assume this is a T1, and let's assume that the whole thing is bright. It's occupying 95% of the canal.
And this, here's another view.
Yeah, you can orient a little bit better here. You can see the fecal sac is a crescent on our left, and the lesion is again bright, not entirely homogeneous, but rather homogeneous.
Interesting that this man was neurologically intact, just back pain.
Can you circle the lesion here so everybody can?
Yeah, my laser thing died. But you can see that big bright thing. It's a massive mass, and the patient wasn't that bad. I mean, just low back pain. So here's just a couple more. It was very heterogeneous. So I was concerned about that.
That does not look good. Even on the right, that looks to me like more like an intrathecal mass than an extradural.
It does, Paul. I think with the Achman's razor, I would say that there are others where it's clearly extradural on some images, and we know what this likely is. But certainly really funny things happen with respect to the dura, and you all would know better than I that things can actually dissect intradural rarely. So I think that doesn't change the diagnosis here. It may change, what you need to expect when you operate.
So Kim, what would you ask this guy in the emergency room? We were talking so much doctor, sexting. He said, "Gosh, it's not that. This is hemorrhagic." What do you want to ask the patient like that? Yeah, Dr. Sexton comes back and said, look, this is a hemorrhagic cyst. Okay, well, it's a blood-filled synovial cyst is the way I would describe it. It's still a synovial cyst. It's filled with blood. What would you then want to ask the patient?
Trauma.
Trauma, and what else?
Surgery,
Well, it's not a malignancy in the neglect. So trauma is a good one. What other things make you believe besides trauma? Anticoagulation. How many patients these days that come to our ER on anticoagulation center? Like a bazillion, right? So if someone's on anticoagulation and they had a Valsalva, let's say, and they came into the ER and they were having tons of pain, and you got this and you examined them and you said, oh yeah, you got a normal exam. My expert told me this is, synovial cyst, it probably has a fair amount of blood in it. In addition to synovium, cells, protein, everything else. But would you say, okay, you're good, call back to Portolani's office in a couple of days, follow up in a few weeks, I'm on Xarelto?
We treat it like emergency, like any other surgical reason. Obviously, the patient's neuroattack, but if you back to home, they should be monitored for changes in that 24 hours and holding Xarelto. If they're on something that's reversible, you should make a plan. You have to discuss with somebody to plan to reverse it.
Absolutely. But what could happen?
Depending on where it is.
Well, like it is
Cauda equina,
Cauda equina.
paralyzed, if it's higher up.
You think that can happen if you get a cauda equina?
Yeah.
For sure. I've had that. Got a call at 6 o'clock in the afternoon on a patient of mine who had previous laminectomy, and he is on Coumadin. He developed bleeding into the synovial cyst, and he lost complete control of bladder bowel function. It definitely happened. So this person really needs to be monitored really carefully. And you have to ask if they're on any sort of blood thinner. And we see that.
Yeah, that's a very good point. This guy was not on a blood thinner, though, and he just walked in the office. Totally normal guy. So the workup was negative. This was the only problem this man had. So that was my concern, too. I thought this was intrathecal. I couldn't be sure. So interestingly, this is the only case in 10 years that I asked Hugo to help me at Upper Chesapeake. So we did a full laminectomy, and unfortunately, I didn't record the case. But it was a very heterogeneous, unusual mass full of blood. It was very unusual. We removed the whole thing post-op, and then we did, just because it was just so unusual and big, I ordered a post-op MRI. Post-op day 1, the guy was pain-free. He said, I feel great. I'm going home. I said, well, hold on just a second. Let me get an MRI before you go home, because I'm just curious what it looks like, make sure we got the whole thing out, etc. So we did get an MRI, which I have a couple images to show. I'm just, Carl, for the sake of time, I'm just going to go quickly, okay? So, I mean, it shows like a big mass there, doesn't it? Like a huge mass with severe neurological compression. Patient is completely asymptomatic and felt fine.
Well, this brings up what does the spine look like normally after you guys operate. And it's a good thing you don't ordinarily get these in people who are doing well, because I've got a fair number of them look like this. Now, I agree, it looks like this patient should certainly have symptoms that this is something where you might even be consider going back.
If this came through the ER,
yeah,
it would be a big alarm.
Right, people would be on the phone.
Yeah.
But
it's interesting.
It is. I think don't look if there's no need to look, because God knows what you'll find.
And there was a study actually published looking at MRIs within a month of surgery, and they basically said they're unreliable until after a month, because you always see epidural hematomas and fluid collection in your laminectomy bed. And
something goes in that space. Yeah, there's no vacuum. Something has to fill the space with blood.
So that's a very common finding.
Did you submit this, was it associated with the facet or just?
I'll show you. Yeah, it was a hemorrhagic facet. I have the path,
It was
but
extradural?
yeah,
It was extradural?
it was completely extradural. And the other thing I find interesting is, and tell me, you guys, if you think it's wrong, is sometimes the dura does expand, but sometimes it doesn't expand. And I decompress, and I'm like, oh man, why isn't the dura expanding? Remember, Dan, the other day we had that? It just doesn't expand sometimes.
Did you actually, see, in my case, when the dura doesn't expand, you haven't actually removed the exterior-most part of the.
I know,
the
you haven't gotten the
whole. You
whole.
don't necessarily have to do, but if you truly get down to dura and you find that plane between the cyst and the dura, it will
You think it's still compressed somewhere, but I don't think so. I think sometimes the dura doesn't expand. It usually expands, but not always. Yeah. So. Yeah, over time. So just a couple. So just the path. I'm not going to go over this, but it was a complex synovial cyst with blood in it. Okay, so we've seen all three types: more serious mucinous, mixed, hemorrhagic. So what do we do now? What are your thoughts? So Justin, did you see the whole case? So it's for L405 fusion, a right foot drop, and he has now this large facet cyst, 6 months post-op. What are your thoughts about treatment? Right. It's right. There's two. There's a big one and a little one. The foot drop's on the big side, on the big one side.
It doesn't look unstable. He's got a lower rectal thesis there, but there's clearly some kind of mobility.
I'm sorry, I didn't show it, but the flexion extension views, no instability at L3, L4. Normal alignment.
So I tell these patients, look, my goal is to go in there and decompress the cysts, both sides, bilaterally. And I probably would leave the spinous process at full impact and do a bilateral laminectomy, really open that space out. And if there was evidence intraoperatively of significant instability, so I'd wrap the spinous process with a filter and just try to shuck it. And I know it's completely subjective, but if it seems grossly unstable, then I'll just go ahead and fuse it. If it does not, then I'll leave it alone.
Is that Paul? Is that your thoughts, or what are your thoughts?
In my experience, I've done a bunch of just unilateral decompression. If a person has a stable segment below, for example, a 4-5 degenerative spondylo above a kind of very marked degenerative 5-1 disc, I think the force is such. In this case, with bilateral synovial cysts, I would plan on fusing that patient because I think that the chance of this becoming, developing instability or recurrent synovial cysts is very high. So I would probably recommend doing a decompression and extending the fusion to 3.
So your concerns is that over the course of 6 months, this guy had bilateral facet cysts, very big ones, and hypertrophy of the ligament flavum, all within 6 months, above a fusion.
Already fused,
yeah. So
I think, and if there's little reticulostasis of 3 on 4 you're seeing on the MRI. So I just think that I would have recommended extending the fusion as opposed to doing just if it was unilateral and it was unilateral pain.
Unilateral symptoms, no less than.
I would consider maybe just a laminectomy, but with bilateral synovial cysts, I think I would go ahead. I'd fuse the patient.
Okay, Dr. Durai, just so we go over everybody, what are your thoughts? Anything to add?
No, I would
Okay. Messman's not here. So, okay, so I agree with what everybody said. Now, I discussed it with the patient, and the patient goes, Doc, I don't have any sick time. I'm going to get kicked out of my house. If my wife's sick, I can't go through another fusion. I like you, and you did a good job. I just can't do it. Can you just take the facet cyst out? So I said, okay. So I did it through a unilateral approach on the left, which is unilateral laminectomy, bilateral decompression. The cartoon on the right is a full laminectomy. And this just happens to be someone I saw last week who has stenosis above my previous surgery. And you can see you can decompress both sides of the spinal canal. And I think it's kind of interesting with it, the whole thecal sac kind of shifts towards the decompression. So you don't fully decompress the opposite side, but I have found it's good enough. Yeah.
You, one of your papers talked about percutaneous treatment in IR of these.
Yeah.
Could I just spend a minute?
Yeah.
Okay. So, one of the papers Spiro sent out talked about percutaneous cyst rupture, deliberate cyst rupture, probably some steroids. And so I have experience injecting the facet joints. I've been asked a time or two to do that in the setting of a facet cyst. First of all, while we're getting a big dose of them today, they're not that common. And that's by way of sort of laying the groundwork of can we, as interventional radiologists, help you all when you don't want to operate or you want to see if it works. So these are the things that are pros and cons about that. One, using CT, and that's how this paper did. I think it came out of Europe, and they must be a center for this because they have 100 of these, and I've probably seen 25 in my career. So they go into the back of the facet joint under CT guidance. They inject contrast to show that they're in the facet joint. Then they inject saline with the notion that they will go through into the cyst and rupture it under pressure. So there are some cyst joints that are dead easy to get into. Okay, any of us who work with CT and the spine can get into this one. This one sort of intermediate in terms of getting into that, and there are a number where it's so difficult that the paper talked about using a 14 gauge cutting needle to cut through the facet into the joint. Then you're rupturing the cyst. Now, if the cyst is soft, like the purely bright, then you have a pretty good chance at that. But if the cyst is all crusted in, like you all know better than we, the chances of doing that seem remote to me that you'll actually rupture the cyst. And then there is the concern for creating a havoc by forcing a lot of saline into this and seeing what happens. So my conclusion from looking at my paper is, and somebody who's gotten into a number of facet joints over the years, that in the right hands, we may be able to help with that technique. But there are a number of strikes against us, and so, and the main one being that we don't do this every week, in which case we would have experience, you would have experience, etc. So I'll take any questions about all that, if I go to Spiro.
I think it's a good comment. I think that at least in my practice, I will try to have the cyst aspirated or the aspiration or attempt at cyst rupture. Wow. I think that works maybe 20% of the time, maybe, and you get people long-term benefit. I think most of the time it's just the effect that after whatever the procedure is done, and they're up to the steroid injection.
Yeah.
But I don't see it being hard at this point.
Okay.
Good. So to do that, if the patient has a foot drop and neurologic, that's still.
No, totally different set of surgery.
Okay, so with the normal neurologic exam, yeah, this patient with a foot drop, I think it's a sort of a little higher risk if you're going to go and attempt to.
I mean, I've seen for cysts go away.
For sure.
So, yeah, but I mean, obviously that's not this case. So it's just an artist's showing you how to do the unilateral laminectomy, bilateral decompression, and just a couple more images. That's not too bad. Okay, so lateral is inferior. The top part towards the ceiling, that's the posterior spinous process, medial. And you see that here's the mass, and see how it's very heterogeneous? It's got, there I just opened up the central part and decompressed it, and some of the fluid came out, but still, it was a very heterogeneous mass with scarring. Also, just to note, it was very adherent to the dura. So the first thing I did was, with the Penfield 4, does everyone see where we are? I mean, the first thing I did with the Penfield 4 is, can I get this whole thing out in one piece? And they're like, there's no way. It was completely adherent.
What do you think is the chances of getting a cyst update when you're doing a cyst removal versus a discectomy? What is there? Do you think the risks are the same, different? If they're different, what's higher risk?
So I would think, especially in a case like this where Dr. Antonades is describing a high degree of adherence to the dura, I would assume the risk would be higher.
For sure. Yeah, man. One study that Sarah quoted, it can be 8%. I've seen studies where it's even higher than that, 15 to 20%. And most people aren't reporting a lot of their dural tears, so these can be unbelievably adherent to the point where sometimes the dura and the cyst wall is just one and the same. There is not a plane. So, like Paul even mentioned, sometimes you have to just float the cyst wall onto the dura because it's not going to come off. You can spend all day trying to get the plane, but you just won't get it.
Yeah, so I agree with all that. So I just tried to get it all the way around. It just shows you. So you can see I'm trying to create a plane. Yeah, I'm trying to create a plane between the two. The other point I want to make is I used a plastic sucker tip, and in the lumbar spine, I do the whole operation myself because I feel I have to, because I have proprioception with the plastic sucker tip because I can feel as I pull, I can feel the dura pull with the suction tip, so I know it's connected. So it gives me a sensation of where I am on the dura. That's why I use the plastic, because the plastic sucker tip bends. So you have a little more give than the metal Fraser tips. So then I went to the opposite side of the table here and just decompressed the lateral recess. And I just kept slowly continually removing pieces. And I just, the other thing is I pull on these cysts and see if you can just pull it out and then see if it's tugging severely on the dura or if you can just sort of tease it off the dura. But I think that's it. Any other comments? I thought it'd just be interesting.
I think that view is sort of what you're showing you, that sort of undercutting the facet where the side where the cyst is.
Yeah, the facet's by the ceiling.
Remember when you're doing this on the hand or the wrist, you want to get the entire ganglion and the stalk that goes into whatever joints are drift, or the classic teaching. So the stalk here goes into the facet joint. So you really want to expose that medial facet joint, get the whole capsule of the medial facet off. So you're really looking and decompress the entire lateral recess. I'll usually take a curette, just a straight, non-angled curette, and run it right along that entire medial facet to make sure there's no capsule there and to kind of roughen it. So hopefully you'll just get fibrotic material that the cyst will not recur. But really kind of debriding the medial facet and the synovium that's there.
Just a couple comments I'd like to make. That one of my partner's mothers who had a synovial cyst turned out that it was a PVNS. So, pigmented nodule synovitis. So that's just another thing to think about.
Did it look hemorrhagic on the MRI?
Yeah. No, well, it did, but when we actually analyzed it, it was PVNS. So.
But preoperatively, did you think it was a hemorrhagic cyst, or just looked?
It was a synovial cyst. I didn't analyze that, but it's just another presentation. It can occur. That can occur in the facet joints. The other comment is, what I also do is, and I've started doing this, I don't know why, if it makes any sense, but I will actually take my bovie and put a hole in the posterior capsule after just to give an egress of synovial fluid. So will it decrease the chance of recurrence? I mean, I don't know.
So it won't go into the canal.
Yeah, so I just make a bovie little hole in the back of the facet joint capsule to allow fluid to come.
Think about that, because in the knee we close the synovium tightly. We don't want a synovial fluid coming out in the knee surgery. So in the spine, we don't do that. There's no way to stop the synovium from going to the canal. So that's a good idea.
I mean, it just,
To give it another-
makes any difference, but it just intuitively made some sense to try it, and that's what I do.
So, so any other comments, anybody? Or questions? So this is just,
The other question I have is for Heath. Why did this patient present with a drop foot? L3-4 synovial cyst, why do you have a drop foot? Would that be the anatomical finding you expect?
Yeah, I would expect L5.
Okay, so why do you have a drop foot?
So I suppose if it were central enough, then it would affect the traversing nerve root. So it could get L5. I suppose.
Can't really think.
It's getting the traversing L4 nerve root, which happens by HL.
Well, you said tibial anterior drop foot, it can be tibial anterior.
Well, I think there could be some possibility of getting HL and L4.
Yeah, so important point. You can L4 root, a person's tibial anterior can be primarily L4 as well. So I've seen patients who have clearly L4 really blocking the drop foot. And so there is some crossover there. Don't think that just because the drop foot is L5 root, it can be the L4 root as well. Okay?
let me ask you something. I always think,
more likely at L5, almost always L5, but tibial anterior can be 4 or 5.
I always think a nerve can be one off. Like sometimes instead of someone's innervated C5, it could be C6. Do you agree with that?
Well, in anatomic studies have shown in the cervical spine, there's clearly a lot of crossover, more so than a lumbar spine. But clearly in the cervical spine, the anatomical dissections have shown that you can get C6, C7, there's more crossover of the nerve rootlets than there is in a lumbar spine.
So it's 2 weeks post-op and post-op x-ray, and this is him 2 weeks in the office. He was a complete right foot drop, and now his right foot, you can see he can almost walk normal on his heel. So this is a lucky case that it came back. But I usually tell patients, I don't know if it's going to come back or not. And I was surprised how well he did.
I think the fact that you did a unilateral approach and you did not disrupt the interspinous or spinous ligaments or the contralateral side, I think that's a great approach to this. I think that was very much better than a bilateral laminotomy. I think
I would be worried about it. If I did a full laminectomy, I would be concerned about it. I would just talk him into the fusion.
I think
I don't want
that's
to
a
do
good
that.
approach, the MIS type approach to get bilateral decompression.
Yeah, so that's all I have today. Does any questions at all about cysts? Or?
I would just make a couple other comments when you're removing these, like a hemilaminectomy, to do a microdisc is a great approach because the disc tends to be kind of right in front of your approach. But to do a hemilaminectomy isolated, like you do for a microdisc, to get the facet cyst, the hardest part is undercutting the facet joint when it's fixed laterally or exposure. So you want to be able to see across the table like what you did. If you want to be able to see across, you can get under that joint really well. And there are times when the synovial cyst will actually go proximal. So let's say it's a 4-5 synovial cyst. Usually it's going to get the L5 traversing route, but there are times when the cyst will actually go up into the L4 foramen. So you have to really reach up, and that's another, for me, another indication for fusion. If I don't think I'm going to be able to get that intraforaminal portion of the cyst above, then I'll just whack the whole facet out and use it. So when I'm looking at the sagittal MRI, I'm really looking at both foramen to see if, make sure you don't get fooled and miss the cyst having that proximal. But I think the decision about whether or not to fuse these patients that when they don't have gross instability, that's one of the things I battle with all the time. I've had some patients come back with a recurrence very quickly and they test. Even though you say, hey, well, you can fuse you down the road, don't burn anything.
They're still upset, even if they know it. People are upset when they come back and need another surgery. Yeah, and you're upset too. You're like, I wish I had fused this.
Yeah. But when you see in the studies, an 8% recurrence rate, doesn't make you want to fuse it. I mean, what's the 8% chance that someone's going to be adjacent level fusion after you fuse that level?
I think this guy's higher than 8% because it's bilateral. mean, it was so quick after the fusion, 6 months. So I don't know.
What about getting cysts in the thoracic spine? Megan, do you think that's possible? We're talking about cervical and lumbar. What about thoracic spine? How would those patients present if they were to get one?
Sometimes you can have pain that wraps around their chest.
Okay, so thoracic radiculopathy. What else?
And it's
What are the neurologic structures in the thoracic spine beyond the nerve roots? No, the neurologic structures. Yeah, spinal cord. Okay. Okay, so when you have a cyst in the thoracic spine.
Yeah, I'm sorry, you'll have more similar to cervical where you have
And would those be in the upper extremities or the lower? Lower extremities. So if someone presents with upper motor neuron findings in the lower extremities with sparing of their arms, and their cervical spine MRI scan is normal, you got to get the thoracic and not just the lumbar, right? Because those patients present with myelopathy. So that's a key thing to remember as well. Thoracic cysts present with myelopathy and ataxia.